I don't see Paul.
bareba baracyari ku manywa y'ihanga ariko bajyaga mbahamagara akenshi iyo ndi muri Amerika igenda bajyaga mbahamagara muri hano muri kuri abashoboye kabaga tsinda.
Hi, Paul. Hello. Is it going to be okay for you to take your mask off?
Yes. Yeah, I just.
You're alone in the room now?
I am alone.
Okay.
Close the door and dropped off my computer so you can space properly.
Okay, you can introduce Paul. Gordon?
Yes. Okay, we'll begin. So
Sure.
my name's Gordon Francis. I'm a member of the Division of Endocrinology and Metabolism. And it's my great pleasure today to introduce our speaker, Dr. Pol Darras, one of the new members of the UBC Division of Endocrinology and Metabolism. Paul is a native of Vancouver and did his BSc in cell biology and genetics at UBC, and then a Master's of Experimental Medicine with the pulmonary group at the James Hogg Research Center and Center for Heart-Lung Innovation, followed by his medical degree at University of Manitoba, and then internal medicine and endocrinology residencies here at UBC. And this last year, we've been very fortunate to have him as our inaugural Beatty Family Fellow in Lipidology and Cardiovascular Disease Prevention. The Beatty family made a very generous donation through the St. Paul's Foundation for 5 years of funding for this fellowship, which is aimed at cardiology, endocrinology, and internal medicine or other related specialists interested in cardiovascular disease prevention, and can also be designed as a preventive cardiology fellowship. And as part of his residency and fellowship, Paul carried out a study using BC admissions and mortality data with Top Data BC to determine the cardiovascular event rates and mortality of patients with familial hypercholesterolemia who have either been treated over a 15-year period, either at the St. Paul's Lipid and Prevention Clinic or managed in the community. And we plan to have the results of that study as a future rounds topic. And as of October 1st this year, we're pleased to welcome Paul as a member of the UBC Division of Endocrinology and Metabolism based at St. Paul's, and a new staff member of the Prevention Clinic. And he will be speaking to us today about an area of great interest of his, CardioDiabetes, a new focus for an old problem. Welcome, Paul.
Thank you very much, Dr. Francis, for the introduction. Just gonna share my screen here. Oh, screen sharing is disabled by host. I'm hoping someone can allow screen sharing for me.
I just I did it on my screen, but I don't know if I'm actually the host. Barry, do you know?
Oh, it looks like it's working now for me.
There we go.
And okay. So yeah, thank you for the introduction. Today I'll be speaking about cardiodiabetes. In the past year, I've focused a lot on lipids, which is another great area of interest for me. There's obviously some overlap in the management of lipids and diabetes, with the goal of reducing the burden of cardiovascular disease, but not too much on lipids today. But thank you for the opportunity to speak to the group here. I have no disclosures to report. a quick review of the objectives for today. One is just to discuss in broadly the burden of cardiovascular disease associated with diabetes, something I think most of us are familiar with. Discuss kind of the history of approaches that we've used to reduce cardiovascular risk in patients diagnosed with diabetes and some of the challenges that have been there. Discuss recent evidence for cardiovascular and renal protection with what would be, I guess, relatively more novel anti-hyperglycemic agents. And then to discuss the, I guess, the organization of care in providing cardiovascular care for patients living with diabetes and what we have in mind for the future, particularly here at St. Paul's. And I'd like to start with just a vignette case. We have a 76-year-old female now presenting for routine care. I've left it vague exactly where she's presenting because, of course, that's the question, how to best provide her care. She has a history of congestive heart failure. Her ejection fractions somewhat reduced at 45. It's actually non-ischemic. She has some non-obstructive coronary disease, mildly symptomatic. She has long-standing diabetes that is not optimally controlled, but reasonable with an A1C of 7.8. She does have chronic kidney disease and quite a borderline GFR, close to 30, with some proteinuria. She also happens to have osteoporosis. You can see her medications here. She's on good medical therapies in terms of rosuvastatin, linagliptin as her only medication for the diabetes. She's also taking ramipril, bisoprolol, a baby aspirin, and then denosumab for osteoporosis. She appears a little bit frail, although as you can see with her cane, she's quite feisty. She doesn't want you to manage her suboptimally. Her blood pressure is 108 on 66, a little bit of edema, a little bit of sensory neuropathy on exam. So there's a few things to address here, and I would say this is not an easy case to manage. And that's what we'll discuss, kind of what the best options are for her. But to start, at a big picture, diabetes is, of course, extremely common. This is data from the International Diabetes Federation Atlas back from 2017, which is the most recent data they have. Worldwide, we're now estimating approximately 425 million people living with diabetes, almost 500 million. You can see the prevalence of diabetes, particularly as people get older, becomes quite significant, approaching 20% in both men and women. So it's a huge epidemic. The vast majority of this, of course, is type 2 diabetes. The burden of cardiovascular disease in the patients with diabetes was first really recognized, I guess, once type 2 diabetes became very common, and more attention came to the cardiovascular long-term consequences. This is from a paper from 1979, and they highlight, the role of diabetes as a contributor to cardiovascular disease has been uncertain, and only lately have prospective population data become available. So this was one of the key findings of the Framingham study, looking at the risk of cardiovascular disease among patients with diabetes. So this is basically the relative risk for these outcomes among patients with diabetes versus without. And you can see a huge burden of cardiovascular disease in general in both men and women. Particularly striking is the heart failure risk that seems to be especially prominent in women, probably because women without diabetes have reasonably lower risk of cardiovascular disease. But when you throw diabetes in, it really drastically increases the risk. There's also increased risk of intermittent claudication, so peripheral arterial disease, which is one of the major manifestations of cardiovascular disease among patients with diabetes, and a walk on the vascular surgery floor would support that, and then increased risk of stroke, actual heart attack, and cardiovascular death. So it behooves us to really optimize the care for these patients, many of whom are exposed to these conditions. We do have more recent data than this from the Framingham, now several decades ago. So this was a large cohort just published in 2015. This is from Kaiser Permanente, and they looked at the risk of various presentations of cardiovascular disease among patients with and without type 2 diabetes. The numbers the risk ratios here are a little bit lower than they had been in the 70s, likely owing to some improvements in care. You do see once again a very striking increase in peripheral arterial disease, with odds ratio of close to 3, but really across most categories of atherosclerotic or cardiovascular disease, the odds ratio for having diabetes is approaches 2. So a huge burden of disease for a condition that is, as we see, very very common. So what can we do about it? Well, initially the thought was, if we can improve people's blood sugar, which is the main problem in diabetes, of course, hopefully we can reduce the risk of the complications, including cardiovascular disease. I've highlighted here one of the landmark studies in diabetes management, the UK PDS, that came out in the 90s. So this was patients newly diagnosed with type 2 diabetes who were randomized to either intensive glycemic control, which would be the initiation of then sulfonylureas or insulin. For the most part, there was a small arm with metformin as well, compared to conventional therapy, which really only addressed blood sugars if patients were becoming symptomatic or fasting glucose above 15. So basically uncontrolled diabetes by our modern standards versus actual tight glycemic control. And there was a reduction in diabetes-related endpoints with intensive control, but really that was strictly driven by the microvascular outcomes. So retinopathy, nephropathy being the main ones. If we look at the cardiovascular outcomes, which we traditionally think of as macrovascular complications, there was no significant improvement despite significantly improved glycemic control. So this was in some ways a disappointing result for glycemic control. There is some benefit though that we can see with long-term outcomes with tight glycemic control. So this was published in 10 years of follow-up of the UK PDS trial, and we see that the patients had been randomized to either conventional therapy or sulfonylurea or insulin. The group with tight glycemic control did achieve a lower A1C. After the end of the study, those differences disappeared as all patients were treated to those glycemic targets, mainly for microvascular complication reduction. And these lines tracked quite closely together. So the differences in the groups disappeared. But over the long term, there was, again, a strong signal for benefit for microvascular disease over the years. But in terms of macrovascular disease, and I've highlighted just myocardial infarction here, some reduction that was never statistically significant, but then trends to becoming statistically significant after a long time. So it appears that glycemic control early on in the course of disease, even if it's only for a short time, leads to a significant improvement down the line. So this is considered the metabolic memory is one term used for this, or the legacy effect of glycemic control. So this drives us to try to achieve glycemic control early on in the course of diabetes. But overall, it's not the most impressive cardiovascular risk reduction that we see with glycemic control. The next step in the history of diabetes management was to look at maybe if we get the sugars even tighter, more tight control, then we will finally see the harder to achieve cardiovascular benefits. Unfortunately, the two large trials that looked at this really did not show that benefit. So this was the ACCORD trial and the ADVANCE trial, both published in the same journal in 2008, and really did not show any benefit in terms of major cardiovascular outcomes. And in fact, in the ACCORD group, famously, there was an increased risk and increased mortality. So this really put a damper on any notion that tight glycemic control, if we were able to achieve it, would reduce cardiovascular disease. So we have a complication that so far has eluded really aggressive management. Lastly, to throw more controversy into it, we were using medications that it was not really clear how safe they were from a cardiovascular disease point of view. And this, I guess, infamous meta-analysis published in 2007 looked at the impact of rosiglitazone on the risk of myocardial infarction and death, and found that there was actually an increased risk of MI and cardiovascular death with the use of this glucose lowering medication. So this raised a lot of controversy, led to really a decrease in the use of this type of medication, rosiglitazone, and to some extent pioglitazone, which we do sometimes still use. But really drove home the notion that just because we're dropping people's blood sugars towards the normal range does not mean we will be improving their cardiovascular outcomes. And in fact, we may be causing more harm than good. So this led the cardiovascular disease prevention to really focus on other aspects of diabetes care rather than strictly blood sugar control. We thought of blood sugar control as very good for preventing microvascular disease, but for macrovascular complications, we relied on other avenues of treatment. For example, something that's near and dear to my heart, statin medications and management of dyslipidemia. There's overwhelming support for the use of lipid lowering in patients with diabetes, as shown here. This is the CARDS trial of atorvastatin versus placebo, and there's a marked reduction in cardiovascular disease. So there were things we could do for cardiovascular disease, just not glucose lowering. Similarly, we have very good evidence that a blockade of the renin-angiotensin system reduces the risk of events in patients with diabetes, both in terms of progression of kidney disease, but also cardiovascular outcomes, including hospitalization for heart failure. So we have strong evidence for these, and these have been basically the mainstay of diabetes management up until the past few years, I would say. And this is reflected. I've pulled this is from the quick reference guide from the guidelines from the Canadian Diabetes Association, now called Diabetes Canada, from 2013. So before these quote unquote novel agents really entered the scene. And you can see that the management is based on, optimal glycemic control, which is again for microvascular complications, blood pressure, and then cholesterol, and then drugs. And the drugs is really the ACEs and the ARBs and the statins. And these were the best tools we had for reducing cardiovascular disease in these patients who are at obviously high risk for it. Things really changed basically starting in 2015 and 2016. So here I have two similar slides. One is from the EMPA-REG trial, which was the first cardiovascular outcome trial for a new class of medications called SGLT2 inhibitors, with astoundingly positive results. And on the right, I have the LEADER trial, which was the first cardiovascular outcome trial in a GLP1 agonist, liraglutide, and also overwhelmingly positive results. Compared to placebo, both of these medications not only met their intended non-inferiority target for not causing more harm, but in fact it led to a reduction in the primary outcome, which was a composite of MI, stroke, or cardiovascular death, with a very significant hazard ratio. The number needed to treat in both these cases was around 60, with only just a few years of treatment. So these trials really changed the game. I believe when the EMPA-REG trial was announced at the I believe it was at the European diabetes meeting, there were tears of joy in the audience, as I recall being told. I was a young trainee at that time, but it was quite an overwhelming moment. Since then, there's been a few more trials, and I don't expect you to read all these titles, but just to show you that there's been an avalanche, so to speak, of more trials that have looked at basically these two classes of medications. And these trials have looked at different drugs, different patient populations, and different primary outcomes. So I've summarized these in this large table, and there's no quiz at the end on exactly what ratios were found in which trials, or even which one was positive for which outcome. But I'd like to highlight some key things about these drugs using the table format to summarize the findings. So here I have all the trials that have shown some type of cardiovascular benefit, either cardio or renal, I should say. You'll be familiar with most of the agents. The trial names are here for your reference, highlighting the population and then the various outcomes in terms of the major cardiovascular events, which is the primary outcome for many of these studies, or else cardiovascular mortality, all-cause mortality, MI, stroke, heart failure hospitalization, or progression of kidney disease, which is, variably defined, but we can lump them together. And I've highlighted the ones that had a positive, like a statistically significant hazard ratio of the medication compared to the placebo in green, and bolded it for you guys. And if you see the ones that have a box on it, I hope this projects appropriately on Zoom. The primary outcome of each study is highlighted with a box. So I'd like to go through some of these things. So first of all, just to touch on exenatide, there was a trial called the Excel trial. This missed its primary outcome. There was a numerically improved and statistically significant reduction in all-cause mortality. I highlight this little lizard. This is the Gila monster. The Gila monster makes a protein called exendin, and this was basically the first recognized GLP1 agonist. There's a few medications that are based on exendin as a molecule, including exenatide. These have had mixed results in terms of cardiovascular outcomes. So a few other drugs that have not shown benefit. And you will notice the name exenatide has a different ending than all the other ones, which are glutide. So the glutide medications are the ones that are based on human GLP1, and those have had more positive results. So the thought is there's something about the human hormone that is somehow superior to this little Gila monster's exendin hormone. I'll touch on albiglutide as well. This was a GLP-1 agonist that we may not be familiar with. It was withdrawn from the market in 2017 by its maker for commercial reasons. There had been concerns of anaphylaxis. That combined with, I think, other agents being on the market and being well established led the company to feel it was not worth marketing. So we will not be using it, but for what it's worth, the trial was positive. And just a quick touch on the semaglutide oral form. You guys, I expect, are familiar with GLP-1 being injection medications. Just recently, we have now had access to semaglutide as an oral medication. It is a little bit tricky to eat. It must be taken on an empty stomach, 30 minutes prior to food, with no more than 4 ounces of water. I've yet to use this medication in any patients that I've seen, but again, I'm relatively new in my practice, as you can imagine. So we will see if this becomes a commonly used option as opposed to the injectables. But overall, getting away from the specifics of each agent, in the GLP-1 class, generally, there's been a pretty consistent reduction in cardiovascular events in terms of the primary outcomes in all these studies, which were the primary outcome being the MACE. There also seems to be some benefit in stroke, which is not the case when we look down at the SGLT2s. So several of these agents reducing stroke specifically. And then also good evidence for progression of kidney disease being reduced with these agents as well in the studies that did report that. So overall, quite a strong evidence for basically a class effect that these medications accomplish these things. Focusing now on the SGLT2 inhibitors, I highlight one, which is ertugliflozin. This, as far as I could see, I was trying to track down the official the official announcement, but it was approved by Health Canada, but then I believe it's been taken off the market since then, again for, I think, commercial reasons. And its trial just came out and was actually negative, so this is a bit of an exception in the SGLT2 world. But otherwise, focusing on the agents as a class, you'll mostly be familiar with empagliflozin, canagliflozin, dapagliflozin. They've had a pretty consistent benefit in terms of cardiovascular outcomes, although this seems to depend to some extent on the population studied. Patients at higher risk perhaps have better reduction. So in the empagliflozin trial, which looked at patients with established cardiovascular disease, the primary outcome was significant, as well as cardiovascular and all-cause mortality. So this led to a lot of excitement. The Canvas trial came out a few years later, also positive for its major cardiovascular outcomes. This was in a population of patients with cardiovascular disease or risk factors for such. Lastly, Declare was the third of the major MACE trials that came out. And this one actually did not meet its primary outcome in terms of MACE reduction. And perhaps it's because the patients were at lower risk, or there's something intrinsically different about that specific agent. So there is, to some extent, a bit of a mixed bag in terms of the primary outcomes. But what has been extremely consistent with these agents, the SGLT2 inhibitors, has been a reduction in hospitalization for heart failure. So basically, every trial has had significant reduction for this, whether it was a primary outcome or not. And also very significant reduction in progression of kidney disease. So there's been a lot of interest with this class of medications, not just from the endocrinologists, but from the nephrologists and from the cardiologists, especially from a heart failure point of view. And that's reflected in the fact that now we've had trials that have come out looking specifically first at chronic kidney disease. So Credence was a trial from a few years ago looking at chronic kidney disease in the context of diabetes and looking at that progression of kidney disease as a primary outcome. And again, really confirmed the notion that these are effective drugs for that purpose, for the purpose of preventing progressive kidney disease. And more recently, just in the past year, DAPA-CKD has come out, which is dapagliflozin in the context of chronic kidney disease. The novelty here is that this is in patients with or without diabetes. So patients with chronic kidney disease and albuminuria, but who may or may not have had diabetes, although over half of them do have diabetes, and we see the same reduction in progression to chronic kidney disease. So suddenly, just like an ACE or an ARB is not a medication we would only use in the context of diabetic kidney disease, dapagliflozin can be thought of as a medication for progressive kidney disease, regardless of diabetes status. Similarly, the cardiologists have got a hold of this, and we now have two trials that looked at heart failure specifically as an outcome, and again, in patients with or without diabetes. So in both of these trials, there was a mix of diabetes and no diabetes, and both trials, their outcome was worsening heart failure or death was technically the primary outcome. The benefit is mostly driven by hospitalization for heart failure here, but both trials have shown a significant reduction in heart failure hospitalization. The one with empagliflozin also was statistically significant for chronic kidney disease progression. So this once again expands the use of these medications, not just to patients with diabetes, but other forms of heart failure. So over the few years, with this expansion of all these trials that have come out, we've found more and more robust evidence for the benefit of these medications, but we've also gradually expanded the population pool that are now proven to benefit from these medications. Initially, when EMPA-REG came out, it was strictly patients with diabetes who had not been at target for glycemic control, which is why they were enrolled, and who had established cardiovascular disease. And then over time, we've had studies of patients with or without diabetes, with or without established cardiovascular disease, and we've seen consistent benefits in those populations. So these are medications that are being used more and more often for those reasons. And this has led to numerous guidelines across the world, really adapting things quite quickly to keep up with this evidence. And the new trials have come at an almost dizzying pace. So it's been a little bit tricky to know what the best practice is when guidelines are already outdated by the time they come out. For example, here's an article that just came out literally in the October edition of the Canadian Journal of Diabetes. So this is the publication for basically an update to the Diabetes Canada guidelines, which is our primary guideline here in Canada. And I've just highlighted here a table that looks at the pharmacological management. So first of all, I want to highlight that one thing that comes up in question is these medications are so good, should we be using them as a first-line therapy? We've had metformin for a long time. We think it's a good drug. Most endocrinologists really believe in it, but do we have something better now that should replace it? And the answer so far has been no when it comes to the Canadian guidelines, and I'll touch on that a bit more. Different guidelines have said different things. But we still believe metformin is first line because it's cheap, it's effective, and all those studies that I showed you are in patients that already are on metformin. So if you want to strictly follow the evidence, you should be having patients on metformin before considering these other agents, certainly for the patients with diabetes. But focusing on what this table shows, there's really two sides to the pharmacological management of diabetes. Now, there's for patients that need more aggressive sugar lowering on the right side, and then regardless of blood sugar control, regardless of what a patient's A1C is, what is their actual status in terms of cardiovascular disease? So from a blood sugar point of view, this is the more traditional, thought that, okay, as endocrinologists, certainly this is what we do. This is what we do for a living. Which medications can we add to someone's regimen if their sugars are not well controlled? There's a clear preference for GLP1 receptor agonists and SGLT2 inhibitors over other agents, given their proven cardiovascular benefits. You'll notice that the sulfonylureas and even insulin itself, our old friend, is felt to be less preferred due to the risk of hypoglycemia, weight gain. TZDs, again, with the controversy around rosiglitazone and to some extent pioglitazone, is also less preferred. So we focus on the medications that have that cardiovascular benefit when we do want to add something for the sake of blood glucose lowering. But regardless of blood glucose lowering, there's a whole other side to the table, which is when should we be adding medications, not for sugar, but for cardiovascular prevention. And here is where we really see many patients that seem to benefit from GLP1 agonists and SGLT2 inhibitors. So the notion that we only add these medications when the A1C is above target is now in the past. At this point, we think of these medications as something that we add just from a cardiovascular disease prevention point of view, based on the wealth of evidence that I highlighted earlier. Strong evidence for GLP1s, particularly for the MACE outcomes. If you look at the heart failure, of course, that's the SGLT2s are the ones with the most robust evidence. And that's the case even in patients who don't have established heart disease or so cardiovascular or heart failure. We recommend these medications if they're felt to be at high enough risk, including the presence of several risk factors. So they also have hypertension, also have smoking, significant dyslipidemia, and so on. So really expanding against the use of these medications. Just to touch on the US guidelines here, this is from the ADA. I won't go through the whole table, but just to highlight that they also believe that first line is metformin, based on the same reasoning that was applicable in Canada, and their approach is broadly similar. I will highlight this was published in the European Heart Journal, and in this case, for newly diagnosed patients with type 2 diabetes who are drug naive, they actually consider the decision point of which medication to start as a first line dependent on whether they have established heart disease or significant risk thereof. So multiple risk factors again, or evidence of end organ damage. And based on their interpretation of the data, they feel that having someone be on metformin is not a prerequisite to see the benefits of these medications. So they would recommend a medication with proven cardiovascular benefits, such as an SGLT2 or a GLP1 agonist up front. If the patient's already on metformin and they have those risk characteristics, then of course adding one of these evidence-based therapies would make sense. And then if only once someone is on these medications, we would consider adding other medication on top of that for glycemic control. And only if patients are not felt to be at high risk would we say, well, you can pick whatever frontline agent after metformin, based on other factors. So really a focus in the European guidelines on these proven medicines up front. I want to touch on a few practical points. I'm suggesting that a lot of patients should be on these medications. Of course, there's a few other considerations, and I can't go into all the details of each medication class, but the big things for GLP-1 agonists, really, one thing to know is that they are quite potent at glycemic lowering. Up to A1C lowering of 1.5 has been reported in trials. It's quite variable. Some patients do very well with these, some less so. The big benefit, of course, is weight loss, and that makes these medications quite popular, despite the fact that they require an injection. Many patients are very motivated for weight loss and will be willing to do that do the injection if needed. One of the main downsides, of course, is the GI side effects. So the GI side effects are very much dose related. And when we start at low doses of a GLP-1, we really get just a little bit of glucose lowering. As the doses ramp up, there's more and more effects on the actual gut and eventually on the central processing pathways in the brain that determine food intake and food expenditure. So with higher doses, we start to get into significantly decreased appetite, reduced food intake, and that's how weight loss is achieved. But if we push the doses too far or too fast, the side effects become intolerable, including nausea, vomiting. So if we start these medications, there's a titration protocol to try to limit those side effects. The other major concern with these medications, of course, is cost. There is no coverage for these medications by pharmacare, even with special authority. So people have to pay out of pocket or rely on their insurance. Just to give you a sense, the annual cost of semaglutide is around $2,600 per year. I was just phoning Costco to confirm these numbers, and the cost for the oral form, if you're curious, is basically identical to the subcutaneous form. If you're interested in trying your patient on that, it's the cost, they've priced it at the same point. Liraglutide, if anything, is even more expensive and probably less convenient with daily injections. So, but many patients are on liraglutide and do well with it. Focusing on the SGLT2 inhibitors, there's a few key considerations. One is that they're not very potent at glucose lowering compared to agents like metformin or GLP1 agonists. We typically see 0.5 to 0.8 or so A1C lowering, depending where you look. These medications will be covered by pharmacare under special authority. There's some requirements, including that someone's been on metformin and has at least tried a sulfonylurea. But at least there is some coverage that's available. And if there's no coverage, the cost here is significantly less, looking at just under $100 per month, typically for a full dose. Some of the major concerns around the use of these medications, though, are the risk of mycotic and urinary tract infections. Most people do just fine, but this can become a problem. If it's a recurrent problem, that would probably preclude ongoing use. There's a small but real risk of euglycemic diabetic ketoacidosis when starting these medications, is particularly in people who may be more on the insulinopenic side of things. So patients with diabetes who are on insulin, maybe their dose of insulin comes down because we have better glycemic control with an SGLT2, and then put them at risk for euglycemic DKA. So something to be aware of. And then the question about the risk of acute kidney injury. And this is something that's a little bit controversial. There is a small dip in the GFR that we see when these medications are started, but this is just by a few points, and this is kind of the expected effect. In terms of true acute kidney injury, we haven't seen a significant increased risk, and some studies actually showed reduced risk of AKI in patients on SGLT2 inhibitors compared to DPP4s, which is probably the most appropriate comparator. So it's not clear that the risk of acute kidney injury is definitely real, but it's something that is certainly on our minds given the mechanism of action and the concern of volume depletion. So based on all these things, SGLT2 inhibitors are part of what we endocrinologists like to call the sad man's list, which are the medications that patients with diabetes should be holding when they're feeling unwell, at risk of dehydration, vomiting, or diarrhea. So SGLT2s are in here. And then specifically around major surgery or any other major stress, to be fair, acute infectious illness, SGLT2 inhibitors should be held. And for scheduled surgery, we like to hold it several days prior to the surgery to reduce the risk of euglycemic DKA in particular. So that's, a review of the evidence in this realm. So going back to our friend Gail here, we can see she's a bit of a challenging case. She has heart failure. Her EF is down. She's mildly symptomatic. Her chronic kidney disease is a bit of an issue. Her GFR is very much borderline for starting any of these medications. If you look at the trials that included SGLT2 inhibitors, because you'd like to put her on one of these, it's questionable whether we can really use these medications when a GFR is dipping below 30. I will note the DAPA CKD trial included patients with GFR down to 25, but the other trials have not gone down below 30. So it causes a bit of anxiety starting these medications. I worry about she has osteoporosis. I don't want her to fall and break a hip, so I'm worried about her volume depletion. She's on a small dose of ramipril. Does that need to be optimized in terms of the management of her heart failure? So I'd really like some input from a cardiologist here, because that's a little bit beyond the scope of my training. So it's a challenging case to manage for any one specialist or a general internist trying to manage all these competing interests in her. So, and this brings me to this notion of, you know, cardiodiabetes. What is cardiodiabetes? So really it's a term that's now being used to describe basically the holistic care of patients with cardiac disease, metabolic disorders such as diabetes. And even though nephrology is not really built into the title, it would be unwieldy to try to fit 3 specialties in here. Nephrology ends up being a big part of this specialty, of this area of focus. And this field of, you know, cardiodiabetes really came into the fore with the advent of these medications that really are these medications are not just diabetic medications. They're not just heart failure medications. They're not just renal protective medication. They're medications that we all share as specialists looking after these patients with these complex comorbidities. So for example, who's going to optimize this person's diet? Well, they should probably be on a diabetic diet. Cardiology should maybe have an input on their salt intake. Nephrology may be commenting, given their level of kidney disease, to manage their intake. So this is very much a multidisciplinary problem. And of course, the dietitian will be frontline in managing this. When we look at glycemic optimization, who's gonna try to see if we can get that A1C under better control? So endocrinology will be involved trying to manage. Certainly if someone's on insulin, endocrinology will have a big role to play in management of their sugar. But of course, the pharmacist, you know, getting approval for drugs or reviewing the polypharmacy, nursing, especially managing, you know, complex diabetes, especially when insulin is on board, and the dietitian, again, plays a big part here. For renal protection, obviously nephrology, pharmacists will be reviewing what medication the patient's on, and then reviewing, especially as their chronic kidney disease gets worse, not just the renal protective strategies, but which medications can and cannot be used based on their renal function. Heart failure management, obviously cardiology will take the fore here, but again, dietitian, nursing, pharmacist to manage, especially when someone has more advanced heart failure and they may be on Lasix, ongoing titrations. So it becomes very tricky to adjust these things. Given the risk of cardiovascular disease, antithrombotic therapies, which is a whole other field I haven't touched on really. But should this person be on aspirin? Should this person be on, you know, is there a role for rivaroxaban depending on patient's history if they happen to have peripheral arterial disease? So lots of complex decisions to be made. The dyslipidemia, I've put the dyslipidemia into the endocrinology group here, although I will admit cardiologists do get involved here as well. But pharmacy, dietitian also playing a role to make sure their lipids are optimized. Foot care, this is more, you know, traditionally in the realm of endocrinology, but also nursing plays a big role here. Cardiodiagnostics, does this person need more investigations? Do we need to sort out more details of their heart function? Sorry, this should be highlighting cardiology, not pharmacist. Weight management, obviously dietitian, endocrinology, should we be, you know, prescribing GLP1 strictly for the sake of weight management? Once someone has established heart disease, do they need to be enrolled in a program like cardiac rehab to try to optimize their physical activity? These are all interdisciplinary questions, and so really the care model needs to involve a lot of these people together. If we look at the management of cardiodiabetes here at St. Paul's Hospital, this is probably not even an exhaustive list, but some of the key stakeholders are certainly, you know, in the Healthy Heart Program, the prevention clinic, which focuses mainly on dyslipidemia, but we do see a fair number of patients with diabetes, patients that are at high risk for cardiovascular disease, maybe possibly because of their dyslipidemia, and we do get involved in their management from that aspect. The rehab clinic is obviously very important for all patients with established heart disease. We also have the Diabetes Health Center, which focuses strictly on diabetes care, and we have a team of endocrinologists, nursing, and dietitians there. Healthy Heart Program, sorry, also is, you know, has an integral nursing and dietitian role. Heart function clinic also will manage a lot of patients with heart failure. Kidney care clinic. So we have a lot of places in this hospital with different teams providing very similar care, and so far they've operated in I don't want to use it's not necessarily silos, because we do communicate back and forth, but it's not necessarily as integrated. And the question is, are some of these patients better cared for if we're able to establish a clinic specifically for these patients with the combination of significant heart disease, diabetes, advanced renal disease, for whom the decisions really must be multidisciplinary. I think any one specialist will be anxious to adjust medications, knowing that that there are implications for patients outside of what is typically their wheelhouse. So I think there's a large role here, and this is something that, in addition to completing some of my research on, really, as Dr. Francis highlighted, the benefit that patients derive by attending the prevention clinic with a interdisciplinary care model, establishing a cardio-diabetes clinic and seeing if we can improve patient outcomes there. And I will segue from there to my thank yous. And I'm highlighting here people who've really supported me in the past year and supported me in what I think is my goal for the near future, which is to establish these relationships and establish more of an interdisciplinary clinic. And I can't tell you many more details of that, but I would say stay tuned. So Dr. Francis and Dr. Brenham, who I've worked very closely with over my past year as the BD Family Fellow, and Dr. Marshall Dahl, who's my division head, has been very supportive in this endeavor. Dr. Ignashevsky, who is interested in speaking to me about a cardio-diabetes clinic and bringing this to St. Paul's, and Dr. Mancini, who's been one of the local gurus in this field. So I have many more people to thank. This marks roughly 6 years of training at UBC for me. So I've had many mentors, but I wanted to highlight these people in particular. So thank you very much. That's my talk for today. I'd be happy to take any questions that you have.
Paul, hi, it's Barry Casson. Thank you very much for that very thorough walk through the trials, the new medications, and the new thoughts. I didn't see in all of your diagrams, and this is not work that I do, general internal medicine. This seems to be, there are elements of patient care rather than having 4 or 5 people that maybe might fit into the wheelhouse, if you will, of a general internist. Can you comment?
I certainly think that's, I felt badly because nephrology is not really in the title of cardio-diabetes, and I also felt badly that I did think general internal medicine is eminently suited to this. Anytime that we talk about care that requires input from many areas of medicine, where people may be a little bit too subspecialized and focus on one part but not the other. I would be very pleased to and for the record, I have gained a lot by working with Dr. Brunham, who brings a general internal medicine focus to the lipid clinic. I would be very happy to speak to when I talk about establishing a clinic. I've not had a lot of communication with other divisions other than some within endocrinology and cardiology, but this is something that I think would fit very well with having an internal medicine component. Or integrating with an internal medicine-based clinic. So absolutely, your point is very well taken. My diagram would have got messy if I had an internal medicine bubble, because it would have been highlighted on every one of those of those points.
Thank you.
Thanks, Paul. That was really an outstanding summary. Other questions from the audience? Please unmute yourself. You can press your space bar to unmute.
Hi, Paul. Can you hear me?
Yes.
Very nice presentation, and I've been long waiting for you to deliver it, and I'm very pleased that you finished the extra year of training with excellent mentors, and that you have completed your recruitment process. But as you correctly pointed out, this field has been evolving so quickly that there is no major conference, be it in cardiology or diabetes or ASN, that would not feature one of the two classes of medications with new outstanding results. When we thought about cardiodiabetes, which I think was even before you started training, I thought about it as this distinctive, a separate clinic, but now I am not so sure, and whether this should be a bricks and mortar clinic, or should there be some kind of a a more modern way of looking at these projects, either by telephone or virtual or email interactions between specialists. We should be able to do that in 21st century.
Mhm.
What do you think? How has you're looking into the field and seeing some of the examples in other parts of the world? Has that influenced your thinking about what we should do here at UBC?
Right. So I agree. So I think one of the key things when I think about this, and certainly in terms of establishing a clinic, I think the important thing is to really figure out what is the actual target what patient demographic, or what types of patients are currently not being well served by the clinics that we do have, and what modification can be made to the system to provide better care. So in some cases, it may be that some of the clinics we do have just need to be perhaps integrated better, or have different, optimized to provide that care. And in some cases, it may be that a new clinic could be beneficial, or a new model of care. And when we talk about cardiodiabetes, I really focused on the long-term prevention of cardiovascular disease. This is really one aspect for which the evidence has been astounding recently. But there's many different areas of need, I think, in this field. And for example, we see many patients with established heart disease who need rapid access to optimization of care, who I think are being underserved. Patients that are on the other end of the spectrum, quite young, and really would benefit from long-term cardiovascular disease prevention, but in many cases may be seen as low risk and would not need to present to a clinic at all initially. So there's a whole spectrum, and identifying where the needs are, I think, is the first step. In terms of around what's been done elsewhere, there are certainly some models of care that focus on that short-term acute management of patients, following a presentation, let's say, with to the CCU. In terms of the long-term cardiodiabetes clinic, there are some clinics, mainly in the U.S., that have an approach of basically being a preventative clinic that incorporate dietary advice, cardiology with risk stratification, advanced imaging, and so forth, weight management, including connections with pharmacological approaches, but also bariatric, which is obviously more prominent in the U.S. So the range is quite broad, and I think we need to focus on exactly where the key gaps are locally, because we have a lot of clinics that are already doing a fantastic job of these things. So I think I wouldn't want to multiply, and build too much redundancy into our models of care, but really identifying where the gaps are locally.
Other questions?
Paul? Hi, fantastic talk, and thank you so much for doing this. One of the things that crosses my mind as I hear you speak is the risk of this kind of approach, aggregating the end of the road patients, the patient with diabetes, heart disease, kidney disease, peripheral vascular disease, etc. And I think to Dr. Cassin's point and some of the points that you just raised here, the profound impact of a change in paradigm vis-a-vis the early steps in management. I mean, I bet Dr. Dahl, for example, hasn't initiated metformin or SGLT2 in a long time because specialists like him are asked to deal with very, very complicated patients. Mm-hmm. Whereas in the trenches, in general practices, community practices, there's huge, simple initial steps in diabetes care that could profoundly affect prevention down the road. Yes. Given the data that you've reviewed, it's just a thought that crossed my mind as you painted the picture of all of these super specialists in a cardio-diabetes clinic.
Right, right, and I think so. One thing I didn't touch on with the epidemic of diabetes. I don't have the numbers in mind, but I believe it's roughly 70 or 75% of patients living with diabetes in Canada are managed, if they're managed at all, hopefully they are, by their family physician. So as an endocrinologist, I think this is my quote unquote wheelhouse. To be honest, I'm only seeing the tip of the iceberg because most patients just get put on metformin by their GP, and maybe that's all they need, and maybe they would benefit from more, but they're missing out. And this is something I think, especially at Tutu, with having a focus on lipids. Lipids is very much something where early treatment of people who are otherwise totally well will make a huge difference down the line. And there's no point in waiting until someone has heart disease to say, okay, now we need to sort out their cholesterol. So that's, I think, a huge challenge at certainly at the population level, to try to bring these therapies and bring these approaches to patients earlier in the course of their disease, certainly.
Thank you.
Other comments? Well, Paul, that's really a tour de force. Thank you for taking the time. I know you've been extremely busy lately preparing numerous talks. Paul's very popular on the presentation bureau right now, locally. And
this is the last one, so.
Yeah, now you can relax a bit, perhaps. Okay, any further comments? Anita is congratulating you, Paul. That's very nice. And I think these presentations are recorded for further viewing. Somebody requested as well. So.
Thanks, Paul. I'd like to be able to announce grand rounds for next week, and I will announce it, but I'm just not certain of the title. We are having it. Okay. Thanks, Paul.
All right. Well, I'll thank everybody for tuning in, and thank Paul again for a wonderful presentation, and see you back next week.
Yeah. Thank you very much for having me.
Okay. Thank you.